So good afternoon, Abby.
Yes, it is afternoon.
Already. All right. Good afternoon, everyone. 12 sharp. So we go for it. I would like to welcome everyone to the Healthcare Federation of Nigeria's Women's Forum webinar for today. And to moderate this wonderful panel of experts and social impact individuals today is Ms. Folarinle Akimilola. And I'd like to quickly go through her bio and hand over to her to take over moderating this session.
Thank you, Yemi. Thank you for that introduction, Dr. Dawudu. So good morning, everyone. Thank you so much for taking time out to join this webinar. I love the topic. It's apt for this time for us. Good morning, ladies and gentlemen that we have on the call. We're glad to have you here for today's important conversation. Her voice, her innovation, spotlighting community-driven solutions in women's health. According to the world, women are not only speaking up about their health, our needs, we're also building solutions from grassroots advocates to frontline workers, from local researchers to bold innovations. Women are leading community-based efforts that are transforming care, access, and outcomes. But too often, these stories go unheard. Today, we're here to change that, or at least attempt to try and change that. This webinar is about amplifying women's voices, recognizing their innovations, like our fantastic panelists, and exploring the power of community-led approaches to address deeply rooted challenges in women, from mental care, mental health, reproductive rights, mobile clinics in driving affordable quality healthcare to the underserved, to improving access to maternal and reproductive healthcare, to public advocacy against gender-based violence, to name but a few initiatives. Together, we'll hear from our wonderful panelists. I can't wait to hear what you have to say. And we'll explore real-world case studies that reflect on how we can support, scale, and sustain these efforts. Because when we listen to women, when we invest in our ideas and uplift our leadership, everyone benefits. Without further ado, I would like to introduce our wonderful panelists today. If you can share their bio, I would love to read their bio to see that we have talented, strong women with us today. Can I see the first bio, please? Okay, so our first panelist today is Dr. Anita Kemi da Silva Ibru, who is a specialist healthcare physician who is dedicated to improving the lives of women and girls through medical practice, social activism, and wider public advocacy against gender-based violence. Professionally, Dr. Da Silva Ibru is a consultant specialist in obstetrics and gynecology, as well as a public health physician with over 30 years experience in medical practice, spanning 3 continents. She's also the founder of the Women at Risk International Foundation, WARIF, a leading nonprofit organization that addresses the prevalence of sexual violence, rape, and the trafficking of young girls and women across Nigeria and Africa. Dr. Da Silva Ibru is a recognized thought leader in the gender space and in the field of women's health internationally. She is a member of the distinguished 2024 Forbes 50 over 50 Europe, Middle East, and Africa EMEA list, and a 2020 TED Talk on the shadow pandemic that gained significant global audience. Dr. Da Silva Ibru is currently the West and Central Africa representative on the UNACT program, Global Steering Committee on Ending Violence Against Women. Thank you very much, Dr. Da Silva Ibru, for joining us today. Good. The second panelist we have today, thank you again for joining us, is Dr. Yetunde Ayo Oyelowo, who is a public health physician, an award-winning social entrepreneur committed to advancing equitable healthcare access across Nigeria. She is the founder and CEO of Market Doctors, a pioneering social enterprise that deploys mobile clinics to deliver affordable, quality healthcare directly to the underserved communities, particularly in markets and the rural areas where women are low-income families often face the greatest barriers to care. Since its founding, Market Doctors has served over 400,000 Nigerians, across 9 states, offering primary care, preventive service, and early diagnosis in places traditional health infrastructure is lacking. A Cartier Women's Initiative Fellow and UN SDG 3 advocate, Dr. Ayo Oyelowo has been widely recognized for her bold, community-rooted approach to healthcare delivery. Her work champions women not only as recipients of care, but also as catalysts for change within the communities. By meeting people where they are, her model is helping to reshape how healthcare is delivered, making it more responsive, inclusive, and sustainable. Through Market Doctors, she is demonstrating what's possible when innovation, compassion, and public health expertise converge. Dr. Ayo Oyelowo, once again, thank you very much for joining us today.
Thank you.
Our third speaker, certainly not the least by any chance, is Muktara Banire, who is a medical student, public health advocate, and founder of Her Aid, a woman-led initiative focused on improving access to maternal and reproductive health care for underserved women and girls in Nigeria. With a background in grassroots organizing and national student leadership, Muktara combines medical knowledge with community action to address the real-world barriers women face in accessing care. Her Aid runs community outreaches, awareness campaigns, and preventative health interventions like cervical cancer screenings. She is passionate about creating inclusive, culturally sensitive health solutions and believes that when women are left behind, everyone is left behind. Once again, Muktara, thank you very much and welcome. Thank you to my panelists again.
Thank you for having me.
You're very welcome. Now, I'm eager to jump into this, but before we do that, a bit of housekeeping. So to our audience, for all your questions and comments, kindly put them in the chat box. We'll get to them at the end of our conversations. And for the questions, if you could please indicate the speaker you would like to answer that question. So right into it. We're going to start with Dr. Kemi Da Silva. I've been looking forward to this, so we're going to go straight into this. And our first question to you today, it's around, obviously what you're doing. First of all, thank you so much for what you're doing. I've had a lot of interactions with you and what you're doing is great. Please keep it up and we'll continue to support you. So our first question today is, what are some ways community-driven approaches have helped to break the silence around gender-based violence and transform women's health outcomes in what you do?
Well, let me start by saying good morning once more to everyone. A big thank you to the Healthcare Federation of Nigeria for this kind invite to this wonderful webinar that I'm totally looking forward to. And special shout out to you, Fola. Nice for us to reconnect once more. Your question is a pertinent one because fundamentally we've established that community-driven approaches is crucial in addressing this issue of gender-based violence. Gender-based violence continues to be one of the most pervasive human rights violations on a global scale. We are still dealing with the 1 in 3 women worldwide encountering physical and sexual violence at some point in their lives. We're dealing in Nigeria with 1 in 4 girls before the age of 18, unfortunately, having one violent sexual encounter. And it continues to go underreported as numerous survivors remain silent, silenced by cultural taboos, by societal stigmatization, and the fear of retaliation. And so, like I said, the community-based approaches have emerged as being one of the most effective strategies. And this is exemplified in the work that we carry out at the WARIF organization. Our overarching objective we achieve through a unique approach, which is our health, education, and community pillar. The focus of the community pillar programs is identifying stakeholders in these communities that we serve, and then providing them with the necessary toolkit to assist not only in breaking the silence, but in actually reducing the cases and essentially transforming the lives of the women residing in these areas. The first aspect we always focus on is training and education. A specific example that I would give would be the WARIF Gatekeepers Program, which is a program that identifies stakeholders in many of these rural communities. And then we attempt to change the narrative by implementing and meeting each of them at the point of need. A classic example would be our traditional birth attendants. These are the informally trained healthcare workers in many of these communities, and they essentially stand in the gap, providing healthcare services to both expectant mothers as well as women and girls. When we attempt to implement the program, we recognize off the bat that it's never been done before. We recognize that many of these women and girls seek services in spaces that traditional birth attendants are aware of the cases, but they have no training on how to deal with them. So we present them with a training program so they become first responders to these cases. We provide not only the training and the toolkit, but also a deliberate and extensive clinical pathway so they know where to refer to and they know the next steps to take. The first immediate aspect that is taken care of and addressed is a safe space. You provide a safe space for women to speak on their issues with other women that understand and receive it. This is the first step in breaking the silence. When we implement these programs, we follow a strict monitoring and evaluation. And I can tell you in 2017, when we first started, we had 200 new cases in just 1 year in areas that these programs were implemented. Fast forward to 2025, we have over 15,000 of these gatekeepers directly impacting in these communities. A major second aspect that I believe would make this a game changer is empowerment. We all know we live in a patriarchal country that encourages subjugation of women. We know she's ostracized. She's meant to carry this shame of an abuse perpetrated on her. And unfortunately, she has a community that shames and blames her. So she needs programs. She needs economic empowerment programs because majority of the women in disenfranchised areas don't have opportunities as you would see in urban settings. She knows what to do, she just does not have the skill set to do it. One of which is basic financial literacy skills. Another is informing her on a vocational skill so that she can earn, allowing her to be financially independent so she can leave this abusive environment where she's wholly reliant on her abuser. In so doing, what do? We create mobilization because we recognize the sphere of influence and political will of many of these gatekeepers that we work with. Another fine example are the traditional and religious leaders. In this context, we leverage off their degree of influence. We assist them as natural mediators in many of these communities in making the right decision. And by so doing, we're now engaging them to change the community norms and practices and holding the perpetrators accountable. We do this in partnerships, not just with the local organizations, but also with the government, because we recognize that systems change is integral if we're looking at sustainability of these programs. Last but not least, I must mention engagement of men and boys. Programs that involve men and boys in a patriarchy statistically have been proven to change the narrative of not just the women, but an actual defined reduction in cases. Harmful stereotypical practices that are seen in our society, focusing on gender inequality and recognizing the adverse impact this has, is one of the areas that at the organization we also focus on. And we do this with our educational programs. We work with adolescent schoolboys on the Warwick Boys Conversation Cafe. It's a mentoring program where we identify average age between 12 and 17, young boys that are in need of role models because they're institutionalized in homes of violence. And they see and they replicate the acts of the male influencers in their communities. And so by presenting them with suitable role models and peer educators, we start to drive that positive change and support gender-sensitive practice. And then we turn these young boys into protectors as opposed to perpetrators. So we have found, without a doubt, that implementation of our community-based programs instills in these communities an ownership. It sustains this change that we're trying to achieve. And this participatory approach has been shown time and time again with evidence-based impact and has been reflected with an improved health outcome. And this cuts across not just gender-based violence, but also just an increase in the availability of mental health resources, which I'm sure my fellow panelists will probably touch on, and therefore a notable reduction in the cases that we see. And this evidence suggests that healthcare transformation is not solely reliant on a top-down approach with initiatives, but rather it can emerge organically from these grassroots programs, yielding long-standing and impactful change. Thank you very much.
Well, thank you, Dr. Da Silva. I was here taking notes as you were speaking. Thank you so much for that. You know, you said a lot of things, and what really got me, well, they all got me, was the part where you're actually engaging men as well. To your point, we really can't do anything without them. We need to train our boys. Our boys need to see what we're trying to make them do, you know, see and, you know, do what they need to do. So thank you so much for that. We're going to come back to you, I'm very sure. To our second panelist today, Dr. Yetunde Ayo Oyelowo, thanks again. My first question to you, should I say, is access to primary healthcare remains a major challenge for many low-income women. How does Market Doctors help to close these access gaps? And what makes mobile or community-based care more responsive to women's everyday realities? Over to you, Dr. Oyelowo.
Thank you, Dr. Fola, for bringing me in. And I'm so glad to be here today to speak about what we do at Market Doctors. I hope I'm audible enough.
You are. We can hear you.
Thank you. Okay, great. So I'll first go back to probably how I started Market Doctors, because that is really important when you want to deal with communities, the purpose of why you're doing what you're doing. That's because, in part, that is what can keep you doing it, you know. And when you deal with low income, you deal with communities, you can't follow a traditional way. You have to go through discoveries to get to where you're going. There's no pattern. There's no research that already says this is how you're going to do it. So you have to go through the research. With my background in health insurance, one major challenge we had, because I worked in the health insurance space for over 10 years. And one major challenge is, how do you get people who were not educated, informal sector, to purchase health insurance? For those of us on this call, I think we're about 56 on this call. If you asked how many people actually have health insurance, you'll see that not everybody here has it. And that still boils down to the culture of, I believe I'm not going to fall ill. I reject it in Jesus' name. This is not, you know, so people already have that when it comes to health. As we sold health insurance, I felt that the informal sector was totally left out of what was going on. They were not going to buy, they didn't understand what it meant. And even when they understood, they had already put themselves on the neck of destiny. What will happen, especially when it comes to health. And that was on that basis I decided to start Market Doctors. And just as the name is, Market Doctor, I felt where is a place where you can really meet people, where in their own natural habitat, and market comes to mind. I mean, in Nigeria, across all cultures, people go to market to buy, to sell, to compare price, and even for gossip. A lot of people here, sometimes you get to the market, you don't even know what you came to buy, but you just go to the stores, visit your customers, and, so I knew it was a place where you could actually meet people. And that was why we took you to the marketplace. Now, getting into the marketplace, I found that you can't also give access to people in the way you plan to. You need to ask them to co-create with you. How can we do this? And that was the question. How can we? It wasn't what were we going to give them. So to bridge that gap, it was a case of dismantling the barriers that made access to healthcare difficult. The first access, when you talk about Nigeria, I'm not looking at Africa, I'm looking at Nigeria, in quote, is affordability. So the white coat, the big hospitals, even if a big hospital says, come in for free, people are still hesitant. Why? Because whether people are poor or they are rich, there is a word called dignity. They always wanted dignity. They didn't want to access care. Then you tell them this is how much it costs and they cannot afford to pay. They wanted that dignity. So they, in Yorubas will say, me fedoti. So to avoid it at all, they don't even go to the hospital. And that's because of the way healthcare has been designed. You go to the hospital, you don't even know how much you're going to spend from point A to point Z. It's after you've taken care that they begin to tell you, this is how much this is how much that is. So people, they don't want that. They want to be able to say what they're going to spend. They needed to have like an average of what is this thing going to cost me. So we created it in that point that how can we say this is how much you will spend when you come to us? So they could say that if they had this amount, they could really come to us. That was one thing in affordability. Then there is acceptability. So acceptability is you can have something very good, but if they don't like you, they don't like you. So also going into the community means we had to be like them. You're not overdressed. You're not speaking Queen's English, we're both speaking the same language, either the local language, pidgin, and so they're not seeing you as superior. They're seeing you as one of them, which was also, and in that way, culture was also part of it. We know that credit is a cultural thing. A lot of times people get something in the morning, they pay for it in the evening. And market women typically, in fact, they won't eat in the morning until they've sold something. So if they don't sell something till 12 o'clock, they're not going to eat. You can't take healthcare to market women on a Monday because they believe that is how they started Monday, that they are going to end. So if they buy paracetamol on Monday morning, that's how they will be buying it every day of the week. So there are a lot of those norms and nuances that, we had to put together and now bundle together and say, this is how we want to deliver this healthcare. So affordability is very big. Acceptability, very big on culture. Then we have the physical access. And that's where I think the boldness came from. I remember when I started, people looked at me and said, you could get a job anywhere else and work in an AC office and, just be fine. Why do you want to go and deliver medical consultations under the sun, to people? And that is the issue of physical access. We also need to know that the informal sector, the rural, for some people, it will take an hour for them to be able to get to a health center to get care. It's 1 hour. It's an hidden cost. It's not only in the hour, is in the fact that 1 hour, she's not going to be able to sell anything. She's not going to be able to do anything. That 1 hour may mean the food they're going to eat that day. That 1 hour is also the time she may have to take her children to school or bring them back to school. So the time of journey and the time of waiting for them is critical. It goes beyond just the price they're going to pay there. So we decided, let's take the healthcare to the people. That's a reverse journey of what healthcare looks like. Instead of people coming to healthcare, then let's take healthcare to people. The last thing again is the referral system. So a lot of people have issues that if healthcare met them where they were, they knew what next to do. So if you meet a woman in the market who had a huge lump on the neck, as a medical personnel, the first thing that comes to your mind is thyroid. And the next thing is this person should go see at probably general hospital, this kind of specialist. But when healthcare is not available in the natural habitat, that journey is really very long. The journey goes from scarifications, then to an herbalist, then before someone eventually says, go to the hospitals, it probably starts again at the PHC. And sometimes these journeys are tiring. Eventually, a lot of times people lose their lives. So what we've really done is to take healthcare to people in a way that is acceptable to them, to create it with them and ensure that it is acceptable to them. In a nutshell, that's what we've been doing.
Taylor, now I've seen you MC at events. I didn't realize you were doing something this powerful. Thank you so much. Yet again, me, I'm a note taker. Some of the things you said, and you're absolutely correct. You have to have dignity, affordability, acceptability, and especially the one about Monday morning. You're very correct. It's not only just for market women. As an entrepreneur, you don't want to be signing checks or paying bills on Monday morning. So you're right. The boldness and the fact that, when you go to the market women, you don't go, as you said, speaking Queen's English in your nice suits. I'm sure you go in your Ankara and everything and you join them. So yeah, thank you so much for that. I will be back to you. And, so thanks. So our third speaker, over to you. Last but certainly not the least, is Muktara Banire. And my first question to you is, from your experience developing a grassroots innovation, what specific barriers do women in your community face in accessing quality care? And how is your solution working to change the narrative from the ground up?
Okay, so thank you very much for the question. I think from my experience, one thing that we've seen is just access to knowledge, firstly, because you would find that when you go to this community, when you go to this women, when you tell them about, oh, this thing, you should look out for it, they care, they want to learn more, they ask questions. So the issue here is not that the women don't care about their health. The issue here is that they don't have the knowledge, so they don't know how important this is. And when you don't have the knowledge for something, it's very easy to deprioritize it and just like, oh, it's not important, it's not important. There are so many young women that are living optimally because they feel like, oh, it's normal. And that's also because they don't have the knowledge. Then from knowledge, since we don't have the knowledge, it's like a continuum. When you don't have the knowledge for something, we don't talk about it. And when you talk about it, you don't know if it's normal or not. So we just keep living lives. People have painful menstruation. People have very not optimal health, but you just feel like, oh, it's okay, it's fine. Nobody's saying anything about it. I'm not saying anything about it. So everything's fine until it becomes too late. And that's where our solution comes in. We go to them with knowledge firstly, we educate them, and the response is always very welcoming because then they are eager to learn, they're eager to listen, they're eager to implement. Then once we empower them with knowledge, we empower them with access. Or a good example would be our cervical cancer screening, because then first thing, everybody hears about cancer, but like nobody feels like they'll get it. Like as one of the people has said, that nobody think that they'll be ill. They always say, oh, it cannot happen to me, it cannot happen to me. But cancer happens to people. It's even increasing in frequency. So for our screening, we partner with a clinic to subsidize it, and it turned out was impressive. And we even got people asking, oh, when are we coming to this state and that state? Again, going back to our problem statement that it's not that women don't care, it's just that they don't have the knowledge, they don't have the access. And that's how our solution through her aid is working to change that. Thank you.
Thank you, Muktara. And you're absolutely correct. There's something you said. I don't know if you can give us a bit more information on that, because I think a lot of us on this webinar would like to find out more. Could you deep dive a bit more into your product with cancer screening? I'd like to find out, or we would like to find out, the steps. So, how do you approach the women? How do they take this? And and what the effects, the answers that you've had from this program?
Okay, so it's actually quite a funny story because um, bringing all of this together is a lot of logistics. Trying to get someone that would a center that they could go to for subsidized screening or free screening is another one trying to encourage the women to go because then there's also that I don't think I have the time. Oh, I don't think it's important. So we had to do a lot of publicity around it. You have to reach out to networks of people that already had women, like women networks, different associations had to come in, different basically a lot of publicity and encourage people that okay, just go, just do this screening. It always takes much of your time. And it turned out it was impressive, like I said. People were, like I mentioned, people were asking that women are coming to this other state and to this other state to do it for them. Because then people again, once you prepare people with knowledge, they know how important it is and they want to take that step. So we've already done one part, gain the knowledge, and when we're trying to do the other parts where we were opening up access to them to this healthcare screening. Yeah, thank you.
You're absolutely correct. Knowledge certainly is power. So thank you for that. Dr. Oyilo, I'm going to come back to you. And once again, thank you for what you're doing. My next question to you really is, in delivering care to underserved women, what personal stories or feedback have directly influenced the evolution of your innovation?
Yeah, thank you. So there are a lot of personal stories, but let me try to bring the ones that are really, that really resonate. Is the fact that people generally think that bad things should happen to bad people. And something happened to me just yesterday, which I'll link to that story. Many of our clients, customers, I try as much as possible to let them know me. It's important they know who is behind all the stuff that is happening and say that it's a woman like us and that. But yesterday, I remember we went around visiting our customers, and I was given 15 people to visit. And within the first 1 hour, we discovered 2 were dead. And we were right in front of their shops, and someone just called. When people see you in front of someone's shop, they think the person is owing money. So they bid, what's going on. And we discovered 2 of them had died. And I was shocked. In fact, for me, it was like the end of that visitation. Why? How? And all of this thing happened within the space of 1.5 months. So I'm just saying, and that again just made me know that bad things happen to everybody. Good things happen to everybody. When we talk big diseases, in quote, cancer, hypertension, asthma, those things also happen to people in the informal sector. Those things also happen to poor people, just that they've not had the opportunity to know what their diagnosis is. That's why they just say they died of brief illness and all of that. But the one that really got to me is a lady who was pregnant and who all the time we took her blood pressure. We routinely don't do antenatal care because in the market we refer them, to the centers. But I mean, you can do a bit of stuff for them in the market. And she had high blood pressure, but because she wasn't feeling anything, she would tell you it doesn't matter. No, this is not a first baby. This is this and that is that. And I kept on personally looking out for her. One, because she was young. That was like a third baby. And, I knew her children. And I just felt something must be done to this woman. The last time I saw her, I remember telling her that she must make sure she primary healthcare center and ensure that she delivers there. And the question she asked me was, how much will it cost for her to deliver there? And I gave her an average that if she goes to the PhD, it shouldn't cost much, but maybe if she had like 20,000 when she was going, apart from buying the things she needs to take, she'll be fine. And she said it was okay. I don't know if she was monitoring her timing and all of that, but by the time she was going to fall into labor, it was really tough. from the market. She was moved, in a regular car. She was taken to a maternity home. Getting there, they realized that blood pressure was so high, they couldn't deal with it. From there, again, they got an ambulance to get her to a general hospital. She got to the general hospital. She was already convulsing. She had the baby. She didn't even know when she had the baby. And I went to visit her in the hospital. Of course, the baby came down with CP, cerebral palsy. She barely made it out of it, and we sat down and we discussed, and she said she now understands, all the things I used to say. She almost lost her life, but even beyond that, the baby was not good, and that baby has become a burden, to her. And even to the quality of life, the money she's looking for, she has to expend it on this baby, and that single episode propelled me, because I'll tell you, sometimes I don't feel like doing this work again. Sometimes I really get tired of doing this work. I want to say, it's over, let me get something else to do. But that again told me that there is still a lot to be done. And there is a lot to be done focusing on women, focusing on women's health. When you look at a situation, she's a co-breadwinner for a lot of people in the informal sector. You don't even know who the breadwinner is. Women in Nigeria are conditioned to provide for their children. That is the barest minimum, no matter what it is. They are conditioned to provide for themselves and their children. Whether the man is eating or not is another. So when you come to the informal sector, their drive is about them and their children. But now she now has an additional burden of taking care of a special need child. That propelled us to do more, and to begin to take a step further to ensure, that when we met those kind of people, we try as much as possible to follow them to the last step, because that is the one I'm privy to. I'm sure many more are happening, all around. Another story I would like to tell you is one that happened in Gombe at one of our outstations. So we do things across the country. And this man brought his daughter to the outreach location and says, this girl has been ill for so long. We even think she's an abiku, she's eating up a lot of her sisters, she's just been ill and ill and ill. They didn't know what was wrong with her. But on checking her blood sugar that day, the doctor there found that it was really high. I think it was 200 and something, and he said he couldn't release her to go back home, that he had to go straight to the hospital. Of course, they didn't have any money, so he called the central system and all of that. And we said, okay, let them go. Let's see what we can do to, get it done. But from their location to the nearest general hospital, if the father and the girl would go, they would need 5,200 naira, which they could not afford. So we were ready to pay for the treatment, but to get there was a problem. And they said, okay, they'll go back home and tomorrow they were going to go. Yes, they went the next day. They got to the hospital. I don't think she spent 2 hours in the hospital. And one thing that came to me was, Yetunde, if you wanted to spend, we felt that maybe we need like 50,000. Why didn't we even give her that 5,000 to just go to the hospital, that day and check what was whatever would remain, So sometimes, even at the level at which people are, a lot of things are intertwined. Yes, you've brought the healthcare, you've educated them, but culture, poverty, and I want to say poverty with a capital P. Poverty is really a big thing. And it's intertwined with a lot of social factors, with a lot of what Dr. Kemi is doing, with a lot of domestic violence, where it was the father that came with the girl. We didn't even bother to ask, where is the mother? Who maybe that day would walk to that hospital if she had been told that this is the problem the child was having. She wouldn't have taken it with levity. So, there's so many personal stories that drive us to do what we do and still hope that more things can be done for people. But baseline, which I want to say, yes, I'm a doctor, we're in the healthcare sector. The first push to getting our healthcare indices up in this country is to make sure that people are educated. people must go to school. The time it takes you to convince someone that went to school to take a step is by far shorter than the time it takes to convince someone who is not educated to take a step in the healthcare direction. Thank you.
Wow. Otoyinlowo, thank you so much. The one thing I will say, you made a comment, please don't give up. I know you have some tough days. Please do not give up because what you're doing is immeasurable. Thank you so much. To our audience, please start putting your questions in the chat box so we can start getting to them. We don't have any at the moment. Kindly start putting your questions in there. Thanks. My next question is going to go to Dr. Kemi Da Silva Ibu. And basically, how can we ensure that women's innovations, addressing GBV and reproductive care are recognized, funded, and scaled nationally?
Thank you for that question, Fola. There are multiple ways we can look at this. For me, and I think for most of us, we recognize the human story behind the issues of gender-based violence. When you say to anyone that, have you experienced gender-based violence or sexual harassment? I think confidently, I would say that every woman would probably raise her hand directly or indirectly. And so the issue of advocacy and awareness is so critical, because it's one thing to recognize that we are dealing with a rape culture or a culture that ignores or sets aside this issue. It's another thing when you deliberately launch campaigns where you put this front and center and you say to everyone that's paying attention to you that these are impact women-led innovations. So visibility, creating broader visibility is certainly key. The second point I want to raise would probably be networking and partnerships. We're dealing with a problem that has staggering numbers. We're dealing with a problem that has 430 million women across the world. Nigeria alone, 49% of us with a 220 million population, with over 100 million women. And we're saying 1 in 4 below the age of 18, where a median age in our country is only 17. So it calls for a concerted effort with multiple partners from various sectors. You have to look at the international donor, who, yes, you need in terms of the investment, because funding is indeed a challenge. Currently, less than 1% of any gender-focused funding is reaching local women organizations directly. And so we need governmental and international donors to invest really quickly to tackle not just the issue of gender-based violence, but also sexual and reproductive health. And this has become a pressing economic concern as well, because we know, for instance, that on average, it costs countries 3% to 4% of their GDP annually due to lost productivity and increase in healthcare costs. To contextualize this, if we use Nigeria, for example, our GDP in 2023 was estimated around $400 billion US. If we apply 2% GDP loss, we lose roughly $8.8 billion US annually to gender-based violence and the associated earning loss. So these are significant numbers, and they translate to an economic burden on these countries. We need to also look at other partners, the private sector and other CSOs, again, in a concerted effort in transforming the narrative of this issue. Another aspect that we can look at is policy support. We need robust policy frameworks and accountability measures, not just on paper. We need to actually have tangible change in the policies and advocate for these policies that prioritize and protect funding for women's health innovations. And this is by working with policymakers to ensure that these successful innovations meet national health systems. We need to ensure governments implement gender-responsive budgeting as well in the annual budget scheme. Capacity building, we always talk about mentoring programs to enhance skills. We always talk about ensuring that there are collaborative efforts, both in the academic field, as well as ensuring that this focus capacity builds for expansion, as well as scale. I'm a huge proponent of research and data, and I believe this is an integral part of informing our decisions. Using data to demonstrate the impact helps with our potential funders, increasing the funding. It helps with your partners in terms of your transparency, and then it helps you evaluate and document the effectiveness of the programs that we implement. And I will end as I started, storytelling. We need to highlight these personal stories. I don't look at this problem through the lens of just numbers. These are children, these are women. My youngest now at my Warif Rape Crisis Center in Yaba is 7 months of age. I'm a practicing obstetrician and gynecologist. I go into the operating room every Friday. I take girls and women to repair. I see the eyes, I see the sadness, I see the pain, not just emotionally, but translated to the impact and the long-term disadvantages that these women are met with. And so we need to humanize this issue so we can foster solidarity. And this can be done in our homes, in the conversations that we have, in the workplace, ensuring safer work environments for women, or elevating it to media campaigns so we raise public awareness and keep the conversation alive. So essentially, orchestrating these efforts, gaining necessary visibility, the funding support, and integration into the larger systems will certainly effect a widespread change. Thank you very much.
Thank you so much for that, Dr. De Silva. I'm a business person, so when you talk about numbers, I get really excited. And the numbers you're spewing here is really catastrophic. It's scary. 2% of our GDP. It's scary. A question I would like to ask you now, though, before I go to the next speaker, is what are some of the ways that you use to attract funders, to attract donors for WARIF?
With regards to attracting donors and funders, first we need to establish that this is a global challenge. Shrinking funding spaces is one that we're all seeing, and is one that we're all seeing play out. At our organization, we recognize that our programs are integral to the success and the long-term changes, both systematically and in the lives of each woman that we hope and we aim to achieve. And so we have always been very deliberate in recognizing that we have to present not just an effective program, but an effective program that has evidence-based data to support the impact. You're sitting across the table with individuals that don't necessarily understand the issue because of the cultural nuances in faraway countries. And so you have to bring that to them. You have to explain to them that you need the community to be part of the decision-making of what these issues should be. You need to expand that by ensuring that there's an educational or training program attached to it. You need to go beyond that and explain to them that in terms of the evidence-based data that you're supporting, it has to be scaled. So there has to be a sustainability component to it. You have to show your success with utter transparency. And this cuts across all aspects of the services, as well as integral to your corporate governance in your organization, and so that the trust is assured. And then you deliver. And you deliver based on that promise, and you deliver well. Thank you.
Thank you very much, Dr. De Silva. I'm going to go back to Mukhtar, and I have a question for you. Another question for you, should I say. Mukhtar, for you, what personal or community experience sparked your innovation, and why was it important that the solution came from a woman?
Okay, so thank you very much for the question. I think my motivation is a mix of personal and community because when we hear statistics like Dr. Dasiba has said, we kind of struggle with humanizing it. But if we're being told that 1 in 20 women face the risk of facing maternal mortality, it means that if I already know more than 22 women, somebody I know would most likely face a risk. Again, that brings that home. I mean, we in Nigeria we have very large families. I mean, somebody in your family, extended or nuclear, will most likely face that risk. And I see all women in Nigeria as a community, and almost every month we hear of someone that died through childbirth. And another example would be a family member that was talking to me one day, and she mentioned how prior to marriage she had her blood grouping done, was I think it was an incorrect result or something. So when she got pregnant and she went for ANC, she told that she was rhesus negative. And if not that she was educated enough to go for ANC, she would not have known. And she would not have known that she has to start taking Rogam. And even I think it was even a little bit late for her, so she had a little bit of complications during her delivery. But the fact that she even to that step changed what would have been an otherwise fatal outcome with something that was manageable. And even up to now, she's still kind of worried of getting pregnant because she's so scarred from that experience. Now that is just one out of like plenty stories that we can highlight of people that we know or we heard of that have gone through something like this. And it's very important that the solution to all these problems come from a woman because first thing is that when I'm coming to talk to you about something that matters to you or is important to you, if I look like you, if I'm a woman like you, you're more inclined to listen to me. Also, aside that, the things I understand how impactful this experience can be to me, the things that I also want to be someday a mother. There's also more urgency, more dedication to actually change statistics. Women need to stop being put in statistics that are not good statistics, like, oh, this amount of women are dying every day in Nigeria. We need to take the step to actually change this narrative and save more women's lives. That's my motivation.
Thank you so much. Thank you for what you do. You mentioned something. I'm not sure if I heard it right. You were talking about a lady who basically went for testing. I'm assuming it was genotype testing, and she was, she got, I think you said she was AS, and that's a totally different, that's a whole program that we certainly, as women, as Nigerians, really have to focus on that, getting ourselves tested, our genotypes tested, so we stop bringing, people with sickle cell into the world. But yes, thank you so much for that. And I don't know if the audience will agree, there's definitely a common theme with what our phenomenal ladies are doing. And so the things are education about culture, education, awareness, and stigma. I'm not sure if you've all listened. That theme seems to be running across what all these phenomenal women are doing. So it just goes to show that regardless of what's going on, regardless of what field you're in, these are some of the things that it's common to all of us, regardless of who you are, what you do, or your socioeconomic status. Thank you for that. Before I go on, I'm gonna check if we have any, I can't see any questions yet in the Q&A box. I'm not sure if it's me, but please put in questions, because if you leave it to me, I have a lot of questions and I like to talk, as you can tell. My next question is gonna go to Dr. Yetunde Ayo Oyelowo. Once again, thanks again. And can you please tell us, what are the biggest limitations women face in accessing basic healthcare, and how can locally led initiatives like yours help bridge this gap?
Yeah. Okay. Thank you. Yeah. So, local women, like the first thing is information gap. So a lot of women have that information gap. They already know the old woman's tales from the house, So you still see a lot of them taking a goal, you see a lot of them putting safety pin on their pregnancies when they're going out. You still see a lot of them doing a lot of things that do not really, in quotes, have any meaning or that they can't even explain themselves. why they're doing it. So for me, that's one major thing. Information is a major challenge. So they need to be really educated and reinformed and, to make them understand why they do the things they do. I think another problem that is a challenge is infrastructure. I think over a long time, Nigeria has faced dearth of infrastructure in the healthcare space. So people are already used to, if I go to the PHC, there'll be no doctor, there'll be no nurse, there'll be no drugs. Even in some instances when things have changed, they are still carrying that old mentality that there is nothing there, so I will not go there. And have we moved as our infrastructure in healthcare? Has it moved at the rate it should move in the country? The answer is no. There are still some basic expectations that you will expect when you go to a PHC that you don't get. So how do I drum it into the ears of a woman in a rural area that, am I sure that when she gets to the PHC, she will get this? I'm not sure. So that's also, so that trust, it has already made trust a problem. So they don't trust the system. So we need to get them back to trust the system. The other thing is affordability for us. We are not an NGO, so they pay, but of course, in a measured amount, they pay. And still you find people finding it difficult to pay up to 3,000 naira can be a challenge. And I'll tell you, before I used to look at it at 3,000, 2,000, why is it so difficult? But guess what? A woman that has a whole heap of tomatoes in front of her in the market, the entire tomato, when you buy it, is not up to 20,000. Everything, if you purchase everything she has, or a woman selling vegetables, all the vegetables she has on her, if you buy everything, may not be up to 25,000. And there's the money that she will pay the person she bought it from. There's the money she will pay for the space she's staying in. And, so eventually what income is left? So there is also that problem. So really, the income that they have, they're not going to spend all for healthcare. Another thing is a shift in mindset that we need to really work on. People need to prioritize. How do you keep yourself alive first to be able to enjoy the goods of life? And I don't know how that got into our country, but now you see people saving up, people who are just low income, saving up to have a party, saving up to buy ashwebi, but they cannot save up to get health insurance. They cannot save up to purchase your drugs. They cannot save up to do something that is life-saving for them. If you say, go and get an ultrasound done, and they tell you it's 6,000, they cannot save up for that 6,000, but they can buy a list of 20,000. So a mind shift, and of course, that is largely probably due to what people are seeing on social media, the way money has now become like the god of everybody. Everybody wants to dress well. Everybody wants to come online and pepper people. So, it has become some kind that's the real things. We've moved it, to the backstage, which is very important. But then again, when you look at the scale of priority, like I said, health is not number one. So you have to understand their priority list. The times you see people trying to spend on health is when they are rushed into the hospital. And guess what? Even when they are rushed into the hospital and you are busy massaging the chest, they are still deliberating how they will get the money that they will pay the hospital. So like I said, education, very important. A mind shift, also very important. We've a lot of models. We have the mobile clinics working. We have the community health workers. We also have the problem of the healthcare worker challenge. At some point, it was really very difficult for us to get people to work in the healthcare space. We had to do trainings. Over like 4 or 5 years, we've trained more than 600 people to be upskilled into the healthcare space. And we are the first beneficiaries. We are the first people that will choose those that will work with us. And we send other people to different organizations. Guess what? We get almost 90% uptake. But when you look in the next 1 year, in the second year, in the third year, and you look at the metrics, you see a lot of people want to leave the healthcare space. Why? When you do a makeup, 1 hour makeup, 25,000. And how many people will sit down to see a doctor for 25,000? They will, unless it is, so there is a serious mind shift that needs to happen in this country from the level of our leaders, and also to make it, to make our promises as regards health in the society, because of the lack of infrastructure. There is lack of trust, and people don't trust that they can get anything from the system. Thank you.
Thank you so much for that. And you're absolutely correct, misplaced priorities. Priorities should be, and I'm going to say I learned something last year. There's a saying that's very true. And basically in English, it's like, may God not turn us into a person that only has one prayer point. What it means is that when you have health issues, trust me, every other thing is secondary. So thank you for that, Dr. Yetunde Ayoyilowo. We have our amiable president. She has a question. She has her hand raised. So over to you, Njidi.
Okay, thank you so much. Let me turn on my video so you can see me. It's been really very interesting discussions. And from what I'm hearing, there are pockets of fantastic innovations going on, both from, Dr. Da Silva to Dr. Oyelowo, and a young innovator. So my question is, how do you scale? How do you scale these innovations, or how do you integrate? What are the plans? Because I was listening, trying to figure out again how the Healthcare Federation can also support, or how do we link you up with partners that could potentially integrate or adopt your innovations? So the question is, currently, as you're implementing, how are you scaling, or how are you planning to scale, or do you want to remain small? Over.
Okay, I'm going to assume that's for all three speakers.
Yes,
correct?
it is. Yes.
Okay, so do we want to start with Dr. Da Silva, then Mukhtar, then Dr. Ayoyilowo?
Well, thank you. Thank you, Njide. Thank you, Fola. We certainly aren't planning on remaining small. I mean, we think big or we go home. So let's start there. The second point that you raised, which is valid, is scalability. How do we ensure that programs, our models, our initiatives being implemented now have a sustainability aspect to it that ensures that it can be scaled? And scaling with an issue like gender-based violence is actually not limited to just country-led only. We look at this issue as a Pan-African-led organization because countries of Africa, as we know, have similar issues, albeit more nuanced than you would find in the global north, because of our peculiarities when it comes to our patriarchy, and also our traditional customs and social norms that encourage, sadly, the violence against women. I must add the caveat, which I always do, that we have beautiful heritage on the continent. We have beautiful, beautiful aspects to our tradition and our practices that we uphold, and we should. But again, we cannot ignore the obvious concerns that we have and we see when it comes to the violence against women. So how do we scale? We scale with partnerships. We scale with ensuring, as we have, that our model, which is a unique approach, adopts pillars that can be integrated with other organizations. We have adopted a health, education, and community service approach because we've looked at the issues through post-incident services as an intervention, as well as preventative initiatives to actually take a step back to see how do we prevent this issue from the inception, which is a long game. So I think the first thing is to establish a mandate and implement a program, a framework, or a protocol that suggests that you have scalability in mind. And then you take each of these building blocks, as we have done, and you create tried and tested programs. In the case of our health pillar, we do have free, by the way, services at our health centers. We've addressed the fact that we don't have enough. I mean, across Nigeria, I believe there are only 42 sexual assault referral centers in only 22 states. And so we've partnered with the Federal Ministry of Women's Affairs to adopt a program where we can now look into revitalizing primary healthcare centers and shelters that are already existing, so that we can again look at this issue through scale. The same with the educational pillar and the programs we implement. We're looking at adolescent school children as well as university programs. And we're asking, how do we then implement our program that's tried and tested, impact-based, and then how do we employ other organizations or even other institutions to partner and work with us? And the same goes in the community-led programs that we implement. So yes, HFN is a welcome partner. I can see already synergy with what we do and the partnerships that you already have and the potential gravitas that you come with in introducing us to other partners. I can certainly start with the wonderful panelists with me on this particular platform to suggest that even in a community setting, we already have synergy and we can continue the conversation after this. Thank you.
Thank you very much, Dr. De Silva. And to our second panelist, the same question.
Thank you. So to scale, our plan is just to capitalize on what has worked so far in our initial state, which is Lagos, I started from. And one thing that we're looking at is expanding to a state with high maternal mortality in Nigeria. So we're talking about states in the northeast or northwest. And what we plan to do there is replicate, because now we have evidence that when you give women knowledge, it actually makes a difference. So you plan to also, in line with that, train young people to be health educators, young people that are passionate about making change, because there are so many people like that just want to do something. They want to make a change. They're ready to take on the world challenges. So we plan to bring them together and train them on how to communicate with these women in language that they understand, whether that's like their local languages or like with culturally sensitive education. So we are stopping the barrier of knowledge, and we're ensuring that more women are aware of things we need to do. In addition to that, just like Dr. Dasiba said, we're very open to partnerships because when you put your resources together, you're able to achieve far much more than if you're solo doing it on your own or doing it at a very micro level. When everybody joins hands together, we can create much more change, much more impact, save more women's lives, which is the most important thing. And currently, we've had programs in maternal health space, reproductive health space, and we're currently also looking at doing something in the immunization space because then, like we've established, women would always want to care for their children. If we're trying to ensure that women have optimal health, optimal living status, it means that we actually also have to care for their children. And we already are aware of the rates of the immunization rates in Nigeria are not where they should be. So we're trying to work on a program around that to our plans to scale. And we're open to partnerships that could allow us reach our goals of helping more women, saving more women's lives. Thank you.
Thank you very much, Victoria. And over to you, Dr. Ayoyedo.
Thank you very much. Like I said, our women pay, but also there are some that cannot pay. So we've had a lot of partnerships, and I must really take this time to appreciate our partners who have made the work possible. And especially the big corporates, a lot of them partner with us, and that has helped us to take this work to over 20 states. But how big are we in each state is the question. So we're really very open to scaling, but again, because we have a lot of physical, it makes it a bit difficult. But we've also gone digital. We now have a mobile app. We have different avenues besides being physical that people can talk to us. But guess what I also found? So sometimes when you are digital and you're dealing with bottom of the pyramid, when you are trying to reach them, they're telling you they don't have data. They're telling you that they can't reach you. So, a lot of the platforms has to be really within, in their habitat. So we've done digital, and we're also open to partnerships with health insurance agencies who are interested in delivering care to the bottom of the pyramid, because to deliver to that sector is really different from your normal plans. So we need to sit down, and put it together. It's not something that we just pick, copy, paste, and feel that it's going to work. We're also open to partnerships with government. We've had some partnerships. We even have one that is really ongoing now. And I can say to a large extent that some governments are really very responsive, but sometimes the time is really slow. It's slow when you look at an organization that has to pay salaries, an organization that has to, so you need to look at where you invest your time, but we're really open, we're interested. If we find people who can give an introduction that can move the needle and make it faster, we're really interested in partnerships with the health insurance agencies, whether the HMOs, whether the government agencies, with corporates that want to build their sustainability projects, the CSR on healthcare. We're open to partnerships. And also, we have a lot of partnerships with pharmaceuticals. Because we use their products, so we get a lot of partnerships with pharmaceuticals, people that make medical devices. We've also had a lot of our trainings were actually supported by foreign partners who ensured that we train people over 3 months, over 8 weeks, full curriculum, and with payments. They were paying the people to come to the training. So we've had a lot of foreign support as well as local one, and we look forward to more partnerships. That way, we know how to scale, but we need the funding, the money to scale. Thank you.
Thank you very much, Dr. Oyilo. Thank you for that. So, to our HFN, we've heard what is needed, and I'm sure we'll help where possible. We have a couple of questions in the Q&A box. I'm going to read them. The first question is to Dr. Kemi. And it says, we all know the repercussions of abuse reports, especially in this part of the world, stigmatization or being ostracized. And that means we need to also prepare for this. Once they report, family, husbands, communities abandon them. What plans are in place to help them stay empowered? And that's to Dr. Kemi Da Silva.
Thank you for that question. The question speaks on an aspect of abuse that's sadly one of the challenges that we face. And this is where women that are brave enough to make decisions to leave their homes, their abusive environments, cannot sustainably stay away. One of the aspects that typically she's met with is pushback from her family. Families that are more concerned with the facade of their family name than her protection. She's therefore not offered any support by these families, and she's made to rely on informal networks like churches or organizations like ours. In my organization, on average, in one of our centers where we've seen over 6,000 survivors, we have had statistics as high as 78% from month to month of women recanting, having started the process of reporting their perpetrator. So plans to help keep them away from abusive environments, to sustain them in their empowerment, is an integral part of their reintegration. What we do at the organization is we implement empowerment programs for women and girls. These programs not only emphasize the obvious need to raise awareness and socially empower her to recognize that she should have agency over herself. She should be able to make decisions in her home, regardless of what he says or what the family may believe. But more practical empowerment tools, like basic financial literacy skills. We have women that can count better than you and I, Fola, but sadly is not aware of the banking instruments that she needs to save money. And so we offer her an opportunity to meet with banks who will share with her aspects of care and aspects of assistance that will benefit her by showing her that you may not be able to read or write, but there are biometrics, for instance, where you can keep your money safely because you leave it under your bed, he finds it, he beats you, and he takes the money. Beyond the basic financial literacy skills, we offer vocational skill acquisition. We give women toolkits. Acquisition of skills have to be tailor-made to be practical in the community that she serves. So yet again, you have to involve her in that decision-making process. She may not want to make a basket because nobody buys baskets in her community. She might want to learn how to make a wig because that is what earns. So by empowering her with a vocational skill, one that's practical, one that she's able to utilize, then you give her the basic foundation to be able to make those right decisions down the road. And then you measure this to ensure the sustainability. You measure the number of accounts that have been opened with your programs. So you're not leaving her high and dry. You're monitoring the apprenticeships that she has actually made with the contacts that you've given her with these entrepreneurs. And you see how she's able to grow, not just her, because the beautiful thing about empowering a woman is that you actually empower a community. Thank you.
Absolutely. Thank you so much for that, Dr. De Silva. We have another question here. The second question is to Mukhtar. What effort are you putting in place for change in health beliefs? Over to you, Mukhtar.
A very interesting question because I think it also encompasses all we said so far. Education really is the key, and how we bring the education to the women matter a lot because they are, like you mentioned, they're rooted in particular beliefs, whether it's cultural or religious, or they actually don't have the say over their health in their family dynamics because most times the men are determinants of healthcare for women. So when we go to meet these women, we're not going to outrightly dismiss all their beliefs. We work with them from where they are and talk to them in language they understand. It also helps when you go someone that is familiar with their culture or religion. So if a Muslim is talking to a Muslim woman about beliefs that are not rooted in anything Islamic, but they feel like it is, it's better coming from a Muslim saying that, oh, this is not how it is, this is what is good for you. And they are more receptive to listening. Same for cultural barriers, cultural beliefs. And another thing that one of our speakers have mentioned is that engaging the men to go a long way because again, when in patriarchal society and the men usually have the upper hand most times. So when you engage the men, it's easier for them to tell their women, okay, I allow you to do this because that's how most happens most times. But I think the women that are not educated, they always have to defer to their husband for kind of care they can receive. So that's how we plan to tackle the health disease.
Thank you very much for that answer, Mukhtar. I have another question here for Dr. Oyeloro. It's not showing on the chat, but it's been sent to me on WhatsApp. It's basically saying to Dr. Oyeloro, have you considered collaboration with existing structures, health payment on a pay small, or contributory basis, the virtual booth model of Lagos State Health Insurance Agency, WIMBIS, empowers a lot of these women. But, all these programs leaves out health component for the sustainability of their empowerment. So basically, have you considered working with these organizations?
Yes, thank you. So for the health insurance model, Lagos State Health Insurance Model, I know at different times spoken about it. We've sent proposals and all of that. But, when it comes to a partnership, the two must be willing to agree and the two must be willing to work together. So, we're aware of all of that and we're also looking to partnerships. And I know I've sent a private answer to the person. And like I said, if there's anybody that feels led and has insights, and that could do better introductions, we're willing to partner with them and see how we can do these things better. I also want to add that partnerships I'm looking forward to partnership with Dr. Kemi, because I recall that we had a town hall meeting with our women. We wanted to talk about cervical cancer. Yeah, we're talking about cervical cancer that day and just giving them. And a lady got up, when we said any other thing, and one of them got up and told us, Ma, I want us to talk about feeding bottle husbands. And I said, what is the meaning of this? And they spent another 1 hour talking about domestic abuse. Sometimes you're taking A to people, but people are coming to tell you, look, I'm dealing with B, C, D. So I'm also buttressing the point that what we're dealing with is much more common than what we're even seeing. Then the other thing I also want to tell people on this platform is that when we talk about health, health doesn't just work alone. People tend to think that when you are into healthcare, you can't do empowerment, you can't do some other things, but all these things work together. There are times we've had to invite some of our partners to come and give financial literacy training to our women, because we recognize that before they can even take care of their health, they have to be settled. I remember we had a partner that we worked with at some point that gave us 50 sewing machines, 50 hair dryers, and 50 pedicure machines. And we did a very clean job. It was not, I know you. It was a case of you're registered with us, you're in our community. People cried on that day. Some said they cannot believe that their name can enter that kind of, So I want us, people here, don't think when you're an health institution, it must all be about giving paracetamol. It must all be about, measuring BP. There are a lot of social issues that can also be solved indirectly by empowering people. Thank you.
You're muted, Dr.
Yeah, I'm speaking while I'm used. Thank you so much for that answer. And absolutely, collaboration, we alluded to that earlier on today. Definitely, these three phenomenal women, you definitely have to do something together. And we can see we haven't started. I would love to be part of that in any way. So thank you for that. There's a saying, you educate a woman, you educate a nation. Once again, what I'm hearing with all of us, yet again, culture, education, awareness, stigmatization, and yet again, collaboration. Thank you so much. I have thoroughly enjoyed this. I've certainly learned a lot from speaking to our ladies. I'm going to check if we have any more questions. I can't see any more questions. We have a few more minutes. I have one question though for Dr. Kemi Da Silva before we round up. When you started speaking, you were talking about you leverage on traditional birth attendants or people who help, not birth attendants, people at the grassroots level who help, you train them to be able to do a few things. For me, that's really, really important because I strongly believe as Nigerians, we're different. In my days where I used to bring doctors to the cath labs to train doctors and physiologists, I found out that when I had Nigerian doctors training our doctors, it was a different story. So I really like that idea where you go to the grassroots and you train the attendants or the attendings. Could you speak a little bit more on that in just a few minutes? I'd really like to understand that properly before we close this panel.
Yes, well, thank you for
that.
So our community-based programs that we implement in various communities across the country is based on that pretext that first, 49% of Nigeria is the rural community. And so when we give statistics like 1 in 4, we're not selecting just urban centers. We also recognize the cultural biases and the deeply entrenched trust issues that come when working in many of these societies and communities. And so you cannot work in communities like these without ensuring that you have inbuilt stakeholders as champions. You also recognize that when you leave these communities, you cannot leave these communities without ensuring sustainability in impacting on this particular issue. So as a practicing OBGYN specialist, in implementing our Gatekeepers project, traditional birth attendants were an obvious choice for me. Now, please don't misunderstand that if I were to leave on my OBGYN hat, I can tell you a laundry list of problems I have with her with regards to my maternal mortality rate. I'm sure Mukhtar will confirm this. But I cannot ignore the role she plays. She is standing in the gap as that healthcare provider, and she's the only one that they would trust to do so. And so we engaged them by understanding what the issues are, recognizing that they were natural custodians to the problems that we were tackling, but they were never given any formal or informal training in addressing them. So by training traditional birth attendants as first responders to cases of gender-based violence in their communities, we opened up an immediate solution to the problem. We then went further by creating a clinical pathway between them and the closest health center in the environment. So they were then able to refer these cases and ensure that beyond their services, these women got the necessary services and needs, specifically post-incident services during these acts or even after in the context of counseling as well as social welfare, because these are the, if you will, services that we provide. And so, yes, we see the traction by working with stakeholders. We also work with the security and judicial system by law enforcement training and workshops. And again, we see the traction in ensuring that they take ownership of the judicial aspects, because an important part of healing for any woman is not just the medical and the counseling, it's the justice. She wants to see that justice is served. The third gatekeeper that I mentioned briefly were our traditional and religious leaders. Anyone that lives in Africa, specifically Nigeria, where we are now, recognizes the huge sphere of influence the traditional leaders have in various underserved communities and rural communities, and religious leaders. And so again, they form a natural mediation. And again, they are individuals in the same community that come with the biases that we see. So by creating workshops, by engaging interpersonal relationships with them, by changing their narratives, a very quick example is a recent program that we implemented in the southern part of Nigeria, where we had traditional leaders make formal declarations against harmful practices, specifically female genital mutilation. By standing in their own communities and making these formal declarations, you start to see the tide change, because the men in these communities and women who are complicit from intergenerational, if you will, narrative start to change their ways, because guess what? The traditional leader has made the declaration. So it's all about inclusive participation, Fola. It's all about understanding the locally rooted issues and providing solutions by working alongside not just the experts in the room, but by the stakeholders that are going to impact this knowledge, and doing it with empathy, doing it with trust, and just making sure that it's sustainable and there's long-term impact and adaptability. Thank you.
Thank you so much for that. Well, I didn't think we'll spend it. We have a minute left. So I am going to take this opportunity to thank our phenomenal panelists. Thank you for what you're doing. Thank you for taking time out to come and educate us on what you're doing. Thank you for making a huge difference in the lives of women in Nigeria. You know, there's a saying, and I'm going to repeat myself: you train a woman, you educate a woman, you train and educate a whole country. Thank you so much. HFN, thank you so much for putting this together. It is absolutely crucial at this point. It is important to all of us. I've learned so much from what our phenomenal panelists are doing, and I'm sure all of us on this platform today have learned a lot from what you phenomenal women are doing. Thank you so much for that. I am going to leave that last word, the very last word, to Dr. Yemi Daudu. On behalf of me, Fola, thank you very much and good afternoon.
Yeah, hello, good afternoon again, everyone. I will be handing over the microphone to our Madam President, who's been with us throughout this webinar, to give us our closing remarks. Thank you very much.
I wasn't expecting that either, because Yemi, this is your show. So again, I don't have to repeat it. This is one in several webinars we will be having on behalf of the Women's Forum, which is led by Dr. Yemi Daudu. So look out for more events. Thank you so much to the panelists, really educative, and we are looking forward to how we can support as HFN as well as collaborate through our individual organizations, because behind everyone here who is speaking and the HFN Exco, we also have huge organizations who we work for during the day. So looking forward to further engagement and have a wonderful day. Thank you so much for your time.
Thank you very much.
All right.
Thank you, everyone. And have
Thank
a
you,
lovely
everyone. Have a
day.
good day.
Thank you.
Bye-bye.
Bye.